Now that we've got the successful elements, let's turn to replicating them. It's that easy, right? We segmented, find the elements, and now it's time to sustain, replicate, and scale. If it were only that easy. And we're going to really try to increase the degree of difficulty. Arnold Milstein is going to join us, I think, from Stanford, California, by video. Here will be a big, come onto the screen, and we'll see him in a minute. And then also Sandra Wilkness and Catherine Hayes will talk about the elements of how do you sustain and replicate and scale these efforts. So if you want to get started. And I think Arnie's going to start. Hopefully we'll have him beamed in shortly.
Great. Can you hear me now?
Yes.
Hello?
Yes, Arnie, we can hear
Hello?
you. Yes, Arnie, we can hear you.
Okay, great. So I think I'll spare you the video, and we'll just focus on the slides, which I'll advance quickly. And the charge to this panel was each of us within 8 minutes will sort of share what we think are the most useful thoughts we have about scaling, and then close with some suggested policy changes that might enable more progress. As you can see via my cover slide, as hard as it might be to discern what would work better in terms of lowering the cost of great care for high-risk patients, the challenges associated with once one knows that, with scaling may even be greater. And I've sort of represented that with the dragon on the slide, and those little people to the left. That's all of us trying to figure out once we are clear on how to do it, how we might learn how to scale it more quickly. Why don't we go on to the next slide? Okay, so in terms of within 8 minutes, I thought I'd try to convey this simply and just say there, in scaling, it's funny, I had recently, had my humility on, substantially increased. When I pulled together a national conference with a colleague at MIT, Bob Gibbons, on what do we really know about scaling best practices in any industry. And so around the table were not just folks like me who are interested in this problem for healthcare, but also people who understood scaling best practices in the steel industry, other industrial sectors, as well as in education and other government services. And I pulled away from that, a few ideas that I think were in addition to sort of inducing humility in terms of there not being great clarity as to how to scale best practices successfully in any industry, let alone one with this splintered, with this, I'll call it a confused, a payer system as we've got, which is sort of this mixed model of both government payment and markets, which is a really tough problem to solve. But what basically what might one pull out of that, the aggregate of what I learned sitting around a table for 2 days with people who've thought about scaling across different industries. And I think number one is obviously is to recognize the complexity of the environment in which you wish to scale. And that for me, that was brought home very specifically, as we in our little care delivery redesign lab that we've launched and now are working with delivery systems around the country to test what we think are lower cost approaches to great care. And one of the things I've learned as a consequence of that is that if one has what we think a reasonable amount of evidence that something would lower the cost of great care, what then happens when you go to the average American delivery system? And I think that one of the first things I learned to understand how complex the environment is that in almost every case, when we took a new care delivery model out, one of the first things the leaders of the care delivery system asked was, will this have to will implementing this cause us to have to create change in more than one clinical department? What they were essentially saying to me is that if we came up with ideas that would only affect primary care or only affect neurology, then that was something that they were perhaps prepared to do. But if we came to them with an idea for lowering the cost of great care that required the cooperation and change across 3 or 4 different clinical departments, for the average American delivery system, that was pretty much out of the question. So that was sort of learning number one, is that this is we're still in a situation where the receptor is challenged by the complexity of the job they face simply in delivering care, let alone improving it. Second point is that perhaps as a consequence of this is that some of the things that anybody could have that Everett Rogers could have told us long ago is that if you're gonna have a chance of spreading, in this case, a better care model for high needs patients, try to simplify it as much as possible, and that obviously resonates with the Crossing the Quality Chasm appendix, which I always have loved rereading. That when you're trying to create change in complex adaptive systems, focusing on a few simple rules and the notion of simplicity is generally what scholars of complex adaptive systems have found to make a difference. And then last but not least, the issue of motivating adoption in a splintered payer environment is a tough problem. I've written about it, others have as well. So the only thing you can do, given the fact that the payment environment is splintered, is to think about drawing on other tools. And I think of the tools available, generally, applying tools from behavioral science, what we know about, how you can take advantage for constructive purposes of ordinary cognitive biases that most people face. You have a much better chance of moving forward with something. And on the right-hand side of the page is simply sort of showing you what experimental research has shown to be the most persuasive message to provide the hotel guests who you wish to reuse their towels and linens. Note that there's a number of features of this that are subtle. I don't have time to go into, but they're basically saying it's people like you, people who've stayed in this room, that is the most persuasive message. Why don't we go on? It illustrates, I won't go into details as to what cognitive bias it happens to take advantage of, but it's, I think, obviously, as Molly referred to, taking advantage of the tailwind of cognitive bias, is I think generally a better strategy if you're dealing in very tough territory to cause widespread change. Let's move on to the last slide. Are we advancing to the last slide? Oh, there we go. So I think, when I thought about, as I reflected on the 2 days I spent with scholars of scale, of best practices across industries, I realized there were a number of remaining ambiguities. The first is sort of this question of how much costly contextual tailoring and external support is needed. Obviously, the more that's needed, the lower the probability that something is going to happen. But what I heard over and over again, particularly from scholars who've tried to scale what are believed to be best practices in education, is that you really, for some types of changes, if you're not prepared to allow contextual tailoring, you're going to run into a lot of inappropriate change suggestions, or in this case, suggested best practices that don't fit well. That being said, the second bullet refers to the fact that the second real challenge in doing this work is this notion of allowing constructive adaptation of a best practice in the process of scaling. That's obviously there's some logic to that, but for those of us who've done this kind of work, and I've been active, in efforts to, take the so-called AICU model that I and a group of other people had formulated in roughly 11 years ago, and see it scaled. I've realized in the course of doing that this notion of allowing constructive adaptation is all well and good, but being able to distinguish it from regression to business as usual is extremely difficult. And the last but not least, one of the things that is always held up for people who say, well, listen, it's not that hard to scale success, is they'll pick a prior success in national scaling and just say, why not do that? And there are real applicability questions. We don't really necessarily understand how to what lessons one can draw from particular successful scaling. And for those of you, probably nobody in the room recognizes this person on the far right. someone I was vaguely aware of, but this is the person who sort of led American anesthesiologists in the early 1980s to a very, very rapid, gain in safety of anesthesia. But that being said, when you sort of look back on what he did, some of the ideas, seem transferable to, something that's very process focused, like better care for high needs patients. But there are also some things that were unique to anesthesia, such as the mechanical nature of some of the changes needed to assure safety that really are not applicable. So we were asked to close, and I'll close in 2 minutes by just briefly, suggesting policy changes that might aid in that successful scaling of models for better or best practices for better caring for high needs patients. And I think I think this country, there's a lot of controversy as to how we spend our research money. But I think, I think one idea that wouldn't require new legislation would be to shift a little bit more research money to understand so-called how they really do it. And this just echoes some of the comments made earlier about how much savings is actually going back to the payers and the patients. But as you look, we now know based on this recently published Yale research that there are some places in the country and within those places some care delivery systems that are uniquely fuel efficient in burning health insurance fuel and perhaps getting great quality results. And I think more research and understanding how they're doing it, and then asking which of those things are plausibly scalable. Would be a very good investment that wouldn't require new legislation. Secondly, it's funny, I'm very supportive of the segmentation research, but as I was listening to it, I was sort of thinking about how useful it might be to sort of jump from that to I'll call it Archimedes, son of Archimedes, which is to, be able to make available as a national asset something like using simulation modeling techniques. Something that would sort of continuously take in what data there was available about a patient on behalf of a health system, and converting it on a more continuous basis to concrete suggestions as to what actions would lower the cost of even better care. I think something like that is within the capability of current simulation modeling, and that's where I think I would consider further research investment. And last but not least, someone earlier referenced the idea of bringing together people who are wanting to work on this, so they can get together. The educational community, as we kind of refer to these as networked improvement communities. I think organizations like IHI have done a nice job of beginning to sort of map, what works and what doesn't work with respect to those kinds of nodes. But the idea here is essentially create networked national improvement communities that would accelerate transfer of insights about better care methods, and also insights about better scaling methods. Historically, they focused on the first, but both are equally important. So I'll stop there. Hopefully, I stayed within my 8-minute cap.
Great. Thanks very much, Arnie.